Hello to all. Welcome to the YouTube channel MEDICO'Z Factory. In this session, we are going to discuss another important topic associated with pharmacokinetics, that is distribution of drug. So do subscribe the channel and use comment section to solve your doubt. So let's begin. Distribution. The reversible transfer of drugs between body fluid compartments. Reversible transfer means drug enters systemic circulation from different location and involves various process like filtration, diffusion, etc. After absorption, drug reaches the systemic circulation and drug gets distributed. So, redistribution. It means highly lipid soluble drugs, when given intravenously, get distributed into highly perfused tissue like brain, heart, and kidney, and then get redistributed into less vascular tissue like muscle and fat. This is called redistribution, resulting in termination of action of drug. Termination is by two ways, either by excretion of unmetabolized drug in its intact form or by metabolic biotransformation followed by excretion. Example is thiopenton. So next is drug receivers or tissue storage. So when drugs get stored in concentrated manner, it increases toxicity when used chronically. Example is tetracyclines in bones and teeth, thiopenton and DDT in adipose tissue, chloroquine in liver and retina, and digoxin in heart. These are very IMP examples, so do remember. Mm. So next is blood-brain barrier. Blood-brain barrier means the capillary boundary that is present between blood and brain. Now, it is joined by tight junction which allows certain drugs to cross blood-brain barrier like amphetamine, dopamine, etc. But in pathological condition like inflammation of meninges, that is meningitis, blood-brain barrier becomes permeable to impermeable drugs. Example is penicillin G. Now, placental barrier. Drug administered to a pregnant woman can cross placenta and reach the fetus. Lipid soluble unionized drug radially cross placenta while lipid insoluble drug cross but to lesser extent. Thus, drugs taken by mother can cause several unwanted effects in fetus, and this is affected by lipid solubility, degree of plasma protein binding, presence of transporters, etc. Example is DTC and insulin, which resist the drug to cross placenta barrier. And also remember, drugs with low molecular weight can easily cross placenta, while drugs with high molecular weight can hardly cross placenta. This is actual concept. So do clear this concept. Rest will be easier to understand. So plasma protein binding. So drugs bind to plasma form where acidic drug bind to albumin and basic drug bind to alpha 1 acidic glycoprotein. So now we will see how plasma protein binding is clinically important. So drug get absorbed and enters circulation. Then it binds to plasma protein, which we had seen in previous slide. Then it binds in two way, bound form and free form. Bound form, drug is not active, act as reservoir, that is temporary storage, and drug is released when free drug level falls. Free form, in which drug is pharmacologically active. Second is drugs that are highly bound to plasma proteins have a low volume of distribution. Example is warfarin, phenytoin, tolbutamide, diazepam, and indomethacin. That is important examples. Do remember that. Third is plasma protein binding delays the metabolism of drug. When free drug level falls, the bound drug is released and it may delay drug reaching the site of action. Understand? Fourth is bound form is not available for filtration at the glomeruli because protein binding prolongs the half-life and duration of action of drug. Highly protein bound drugs have a longer duration of action. Example, sulfadiazine is less plasma protein bound and has a duration of action of 6 hours, whereas sulfadoxine is highly plasma protein bound and has a duration of action of 1 week. Sixth is in case of poisoning, highly plasma protein bound drugs are difficult to be removed by hemodialysis. Understand? Okay, so next, in disease states like anemia, renal failure, chronic liver disease, etc., plasma albumin level are low, hypoalbuminemia. So there will be a decrease in bound form and an increase in free form of the drug, which can lead to drug toxicity. So reduced protein binding of drug leading to raised level of free drug. It leads to toxicity. Next is plasma protein binding can cause displacement interaction. More than one drug can bind to the same site on plasma protein. The drug with higher affinity will displace the drug with higher affinity will displace the one having lower affinity and may result in a sudden increase in the free concentration of the drug with lower affinity. So let's understand with example. Warfarin 99% bound to albumin, that is free form is 1%. Another drug is endomethacin reduce its binding to 95%. Free from then becomes 5%, which means five-fold increase in free warfarin levels, which could lead to toxicity. So now we will see factors affecting plasma protein binding of drug. Drug-related factor. First is concentration of drug in the body. At low concentration, drugs are bound to plasma protein, and at high concentration, increased amount of free drug. That increased concentration of drug in tissue can lead toxicity. Second is drug affinity. For example, digoxin has more affinity for proteins of cardiac muscle than skeletal muscle. Lidocaine has higher affinity to alpha-1 acid glycoprotein. Second is patient factor. So let's see how age affect neonates and elderly have low albumin, that is more free drug and increased risk of adverse effect. Second is disease state, MI, renal failure, diabetes, obesity, and lung disorders. So this type of disorder found in patient can affect plasma protein binding. Understand? So that's it. I hope this session is helpful to you. In case of any doubt, use comment section. Do subscribe the channel. Have a nice day. Bye bye.